Good afternoon, everyone, and welcome to this Endo-ERN Rare Disease webinar. We'll just take a moment while people filter in. I'd like to take a moment to thank our speakers for making themselves available today to make these presentations. Just to go through some housekeeping issues with you. The presentations will go on back to back, and then at the end, you will have an opportunity to engage with the experts to ask your questions. During the webinar, you can enter the questions into the chat box, or you can wait till the end and you can raise your hand and ask your questions directly. And with that, I'll hand it over to the organizer, Marco Banomi. Thank you, Marco.
Thank you, and good afternoon to everybody. And welcome to this webinar of the MTG7, and it will be focused on this congenital hypogonadotropic hypogonadism, which is a rare and heterogeneous disease. And we will have today three outstanding speakers, one from Milan, one from Boston, and one from London. And we will talk about the challenging of the diagnosis of hypogonadotropic hypogonadism, but also the reversal form, and finally the fertility points in this disease. So I will share this this session with Professor Klaus Gravold, which is also the chair of the MTG7. And so I will directly give the microphone to Klaus for his greetings and for the beginning of the session. So please, Klaus.
Yes, thank you. It's a great pleasure to be chairing this session together with you. And with that, I would like to introduce the first speaker, which is Biagio Cangiano from the University of Milan in Italy. And he's an assistant professor. And he will talk about precision medicine in congenital hypogonadotropic hypogonadism, genetic diagnosis, and emerging biomarkers. Please, Biagio.
We don't hear you. You must unmute yourself.
Okay, here we are.
Now we hear you. Now we need your slides.
Wonderful, wonderful. Okay, good afternoon to everyone. And thank you, Professor, for your kind introduction. And thank you to Endo-ERN for giving me the opportunity to present about the new biomarkers of congenital hypogonadotropic hypogonadism and its genetics diagnosis. We all know that congenital hypogonadotropic hypogonadism is a rare disease with a male predominance, which has both reproductive and developmental impairment and other signs and symptoms that often contribute to a complex phenotype and sometimes even to syndromes. Indeed, anosmia, together with other features such as impairment of other senses, neonatal undervirilization, and the listed malformation are called red flags, which can be caused by the same genes that cause hypogonadotropic hypogonadism. And thus, we have to think about CHH every time that we found a delayed puberty together with red flags. However, it has to be said that the majority of patients actually do not present red flags, and these are, of course, a specific tool, but not so sensitive. CHH is not always a complete and persistent disease. We know that there are some forms of reversal that will be discussed later in this webinar, which are the restoration, the recovery of the hypothalamic pituitary gonadal function during the lifespan of a patient affected. And even at diagnosis, the disease can not be complete, but partial, mild, incomplete hypogonadotropic hypogonadism with the start of the puberty, which stops during halfway its progress. And these forms are actually quite difficult can be quite difficult to diagnose, since these patients usually present some signs of, male virilization. I wrote virilization, but actually some signs of puberty, and they also respond to GnRH, LH-RH testing. However, the differential diagnosis of hypogonadotropic hypogonadism can be quite complex, but the real challenge in the differential diagnosis of this condition is the constitutional delay of growth and puberty, or self-limiting delayed puberty, which is virtually indistinguishable from CHH, and it is a paraphysiological start of the puberty, which is later than the normal, but before 18 years old, and it often presents with the same features, with the low sex hormones, low gonadotropins, no signs of puberty, and it does not respond to GnRH testing. From this perspective, we can say that the main fault, if we talk about the biomarker and tests for congenital hypogonadotropic hypogonadism, we can say that the false positive results are the self-limited delayed puberty. And we can, in the same perspective, see as the main false negative for CHH, the partial and mild form of CHH. In this context, if we want to have a highly reliable test with high sensitivity, we should pick a test which is able to distinguish also incomplete forms of congenital hypogonadotropic hypogonadism. On the other hand, if we want a test which is specific and that can rule out the main false positives, which are the patients with delayed puberty, we should have a test which has been studied against these conditions. So let's go to see the different biomarkers and tests that we have in our disposition. Let's start with inhibin B. Inhibin B is an hormone produced by Sertoli cells and granulosa cells under FSH feedback, and in males it is often being proposed as a marker of Sertoli cell health and male reproductive health. In this context, many studies have evaluated its efficacy to distinguish CHH from self-limited delayed puberty with a variable accuracy found in each different study, even though they couldn't find a single and a shared cutoff to diagnose this condition. Indeed, the main problem, in my opinion, about this marker is the fact that it is not so sensitive to find the partial form of hypogonadotropic hypogonadism. As you can see in this meta-analysis, as you increase the testicular volume of the subjects that you evaluate, the accuracy of this test drops, and this is mainly because we have a partial form of CHH. Nonetheless, its usefulness in the distinguishing CHH patient from self-limiting delayed puberty is quite promising. And I report here two new studies, both from 2025, which I believe are quite interesting. The first one is this prospective case control study in which male adolescents with delayed puberty were studied using these different biomarkers also of Sertoli cell function, and were followed up until a final diagnosis was made using gold standard criteria. And what they found, these are the patients that were enrolled and how they divided in self-limited puberty and CHH. As you can see, there are also some partial forms. And what they found is that actually the FSH, the product of FSH and the inhibin B is the best, the most accurate biomarker, especially if we are comparing complete form of hypogonadotropic hypogonadism with constitutional delays of growth and puberty, self-limiting delayed puberties. This is a second study, which in my opinion is very interesting, and it study a whole different category of patients. This study evaluated neonatal patients, patients below 1 year old, and these patients were admitted and then enrolled because they had micropenis or cryptorchidism. After that, these patients were divided according to the presence or not of the mini-puberty in the isolated micropenis and cryptorchidism or isolated CHH. And what they found is that after the mini-puberty, at the end of the mini-puberty, the markers, the best detected and at the best accuracy to divide patients who had or not the mini-puberty were actually markers of Sertoli cells, inhibin B and AMH, thus suggesting that inhibin B is a lasting marker of previous mini-puberty. And so it could be a test with very good specificity in distinguishing CHH from self-limiting delayed puberty. It has to be said that, as we were saying a few moments ago, not all CHH have an impairment in the mini-puberty. There are some mild forms, some partial forms that can have a normal mini-puberty and thus result differently at this kind of test. Let's proceed with the kisspeptin test. We all know that kisspeptin is a very important neuropeptide, fundamental for the pubertal development and for reproduction, and which acts on the hypothalamus to make it release GnRH. And because of this biological mechanism, it has been studied through its stimulation of the hypothalamic secretion, and after that LH secretion, it has been studied as an hypothalamic test to differentiate CHH with other conditions. This is the main study that has been published, which compared CHH patients with eugonadal patients, and unsurprisingly, they found that this test is very accurate to divide these patients from healthy controls, much better than the GnRH testing. But the thing that I think is most important and interesting is that many of these patients with hypogonadotropic hypogonadism actually had partial form of it, as you can see from their testicular volume. And this is very interesting because this test actually was very accurate even to distinguish these partial forms from healthy controls. This other study tried to evaluate the kisspeptin test and its ability to distinguish reversal form of hypogonadotropic hypogonadism. And what they found is that it actually is accurate to find reversal in patients with hypogonadotropic hypogonadism. And not only that, but also the relapse was shown to not respond to the test. So the test seems to evaluate the present activity of the hypothalamus, so the present status of the GnRH pulse generator, which is very, very interesting since it helps us to detect the current activity of the axis. In this other study, which is the only one that I found that compared the hypogonadotropic hypogonadism and self-limited delayed puberty using kisspeptin test, they evaluated the patient with delayed puberty with the test and then studied its future if it became a CHH or a pubertal delay. And what they found is that this test seems accurate even in this condition. The fact that the patients that in the end had an autonomous pubertal progression, so they were self-limited, limiting delayed puberty, actually already, and we know that LH pulses, the secretion of the overnight LH pulses increase and start at the beginning of puberty. So it is already a marker that was studied to evaluate patients who would undergo a autonomous puberty, and it is not that good when we study patients which are very far from the starting of puberty, and this could be the case even for this testing. So we can say that this testing is very good to evaluate the current situation of our patient, and partial CHH does not seem to produce false negative to this test. However, we do not know if this could actually distinguish CHH from completely prepubertal subjects. But it is to be said that it seems able to point out patients that are about to start puberty. Finally, of course, all markers and tests must be, we must expand the evidences available on these tests. And in this case, it is also important to evaluate if this test changes its results according to the pathway that is impaired in our patients. In fact, we all know that congenital hypogonadotropic hypogonadism could do to different mechanisms, different situation, different impairments of the generation neuron development, migration, activity, and secretion and action. And of course, we have to prove that each one of these kind of alteration responds in the same way to this test. And this leads me to the last part of my talk, which is about genetics. Actually, genetics is widely used in the diagnosis of congenital hypogonadotropic hypogonadism, and together with the red flags, it adds up to give a quite specific tool for making this diagnosis. Until now, more than 60 genes have been correlated with the CHH, even though produce overlaps with each other, both for its severity and for the associated features and phenotype. More genes associated have an incomplete penetrance and expressivity, which means that if we have the same mutation in different patients, it can give the phenotype or not differently in each one of them. And similarly, that the same variant, the same mutation in different patients can give different degree of severity at different presentation in each one. And this is only in part explained by the unique mode of transmission of CHH, which has already been demonstrated to be an oligogenic mode of inheritance. In fact, we know that different variants in different genes can be synergistic to give the phenotype in each patient. And so this could explain a part of the variable expressivity of our patient, even though it has been proven that it does not explain all of it. So different genes can produce the same phenotype, and each gene can produce different phenotypes due to an incomplete expressivity. This remarks the absolute importance of the NGS techniques when we evaluate the CHH, because if we do not have a complete, portrait of the situation, we can't perform an accurate genetic evaluation of our patient. And this is even more so because the interpretation of genetic variants is not at all easy. We know from different studies that even controls have often rare variants in the genes associated with congenital hypogonadotropic hypogonadism. Means that there is variants found in these genes that are not the cause of our phenotype. And so it is very important to, when we perform a genetic analysis and evaluation of our patient, to understand if the variants found are actually the cause of our phenotype. And to do so, it is important that the genetic analysis is performed and interpreted in a specialized center, which is able, using validated criteria, to interpret the pathogenicity of the variant. This just to remark that once that we perform this kind of evaluation, genetics can be very, very useful, but is tricky to be interpreted. And with this, I conclude my talk, and I would be happy to answer to all the questions that you would have. Thank you for your attention.
Okay, so thank you very much, Biagio. And I think we can now move to so the next presentation will be done by Professor Andrew Dwyer from the Boston College. Professor Dwyer has a very important experience and long experience with patients with CHH. And he will talk about the reversal form of CHH, so the clinical predictors and the strategies for the management of this patient. And so I thank you again, Andrew, for being with us, and I will give the microphone and the floor to him. Please, Andrew.
Thank you so much for the invitation to present. I'll be talking about this reversal phenomenon, as well as some clinical predictors and some pearls about management. So I have no relevant disclosures, but I do receive funding support from the National Institutes of Health. And here's what the outline of our talk today is. I want to talk about the spectrum of CHH and different subtypes because that's relevant for this talk. We'll give a high-level overview of the reversal phenomenon, and then I'll talk about some predictors of reversal, and that will lead into some management considerations, how we can apply this clinically, and I'll finish with some summary take-home points. So some key points about CHH, it's characterized by deficient GnRH secretion or action. Clinically, it presents as lack of puberty and infertility. As Biagio mentioned, it is rare. It's about 1 in 48,000, and it has an interesting male to female ratio of about 4 males diagnosed for each female case. And it is quite challenging to diagnose, although we just saw some interesting data around some novel ways to differentiate CHH from delayed puberty. It's also genetically heterogeneous. There are more than 60 genes that have been implicated in CHH, which only account for about half of cases. And as we heard just previously, there is variable expressivity and incomplete penetrance, and that relates to some of the complex genetic architecture, including digenicity and oligogenicity, when there are 2 or more pathogenic variants found in an individual. Paralleling the genetic heterogeneity, it's clinically heterogeneous. There are reproductive phenotypes which may be present, including mal-descended testes or micropenis. There's also an array of non-reproductive phenotypes, everything from musculoskeletal aspects to sensory deficits, hearing loss. Anosmia is referred to as Kalman syndrome, as well as things like unilateral renal agenesis or synkinesia, the mirror movements. But importantly, it is a treatable form of male infertility. Sex steroids are effective for inducing secondary sexual characteristics, and fertility can be induced in about 75 to 80% of men using either gonadotropin therapy, combined FSH and HCG, or pulsatile GnRH. And for the focus of my talk, I want to focus on this 10 to 15% of patients, of men, who undergo a reversal and recovery of their reproductive axis function. So this is the activity of the HPG axis across the lifespan, and the presentation of CHH really depends on where that deficit appears. So certainly we saw these red flags of cryptorchidism and micropenis can be hallmarks or early indicators of CHH during the neonatal period, although not all patients present with that. More typically, they present with absent or incomplete puberty, underdeveloped genitalia, and perhaps unicoidal proportions as they fail to undergo spontaneous puberty, and thus the challenge of differentiating that from delayed puberty. So in addition to this clinical heterogeneity, there is within CHH, we see both absent puberty, so these are individuals who have no spontaneous pubertal development, a testicular volume of less than 4 milliliters at baseline. And then there are the partial puberty types, which we heard are quite difficult to distinguish. And these are individuals with some spontaneous degree of partial pubertal development. And this figure shows that 242 individuals who had 12-hour overnight frequent sampling to look at LH pulses. And you can see there's an array of, even among absent puberty, the vast majority of whom exhibit apulsatile LH, but there are a few that do have LH pulse patterns. And then among the partial puberty, there's a relatively split between those who exhibit some LH pulses and some who are apulsatile. So within this neuroendocrine heterogeneity, there are also clinical subtypes. So as I said, anosmia with CHH is referred to as Kalman syndrome, and that's about 40 to 50% of individuals, depending on the cohort that's evaluated. There's an isolated normosmic type. There is the Pasqualini syndrome subtype, which is sometimes referred to as the fertile eunuch subtype. I don't like that term because it is quite offensive to many of the patients, but this is a subtype with some degree of partial spontaneous puberty as exhibited by testicular growth, as well as detectable FSH levels. And these individuals do have some active spermatogenesis on testicular biopsy, but yet lack a sufficient androgens to be able to have ejaculatory function or to reach a normal sperm count. There's also syndromic overlaps with other conditions, including charge syndrome, septo-optic dysplasia, et cetera, and then the neurologic form of Gordon-Holmes syndrome. So about the reversal phenomenon, as I said before, there's about 10 to 15% of individuals who undergo this. And this first report was back in 1975 by Rizvani and colleagues. It was a case report at a meeting. And over the next 33 years, there were 17 cases reported in the literature. And all of these started to create this body of literature that they are distinct from delayed puberty. They exhibited CHH-associated phenotypes, including anosmia, Kalman syndrome, and their recovery occurred well into adulthood. This wasn't just a simple case of somebody starting a very late puberty. And there were cases of severe GnRH deficiency, so complete absence of spontaneous puberty, testicular volume less than 4, as well as mal-descended testes or cryptorchidism. And then there were some other cases with milder GnRH deficiency akin to the Pasqualini syndrome. So then in 2007, we conducted a study at the Mass General Hospital where we identified retrospectively 10 individuals who underwent reversal. And then we conducted the first of its kind prospective study where we evaluated 50 men who had been carefully characterized and been diagnosed with CHH. We brought them back in. They underwent a treatment washout, a supervised treatment washout, and then underwent a frequent sampling study to look at LH pulses and testosterone. And as you can see here on the right, the 5 reversal cases prospectively identified maintained normal serum testosterone levels. And I just note that it's nanograms per deciliter, not the international units. And notably that we also found reversal cases in individuals who harbored pathogenic variants in the GnRH receptor, as well as FGFR1. So suggesting that even in the setting of pathogenic variants, there is reversal. And this is just some data to show you that at baseline pre-reversal, you can see this relatively flat LH pulse pattern, sometimes an occasional pulse, but then on the right-hand panels, you see a robust LH activity that's well into the normal range, and those inverted triangles at the top depict LH pulses, and of course, there are sustained normal serum testosterone levels, which according to this system is roughly above 300 nanograms per deciliter. So in the subsequent 15 years, there were another 16 publications and a growing number of genes that had been reported in cases of reversal. And notably, reversal is not always lasting, which we saw that kisspeptin stimulation is useful for depicting that. And then in 2022, we conducted a natural history study of individuals, men with the Pasqualini syndrome, and we found that among the Pasqualini syndrome, they were enriched for reversal. So we compared them to roughly 200, a little over 200 well-characterized, deeply phenotyped men with CHH. 139 of them had absent puberty. 63 had partial puberty, and compared to both of those groups, the individuals with Pasqualini syndrome, which is this very mild GnRH deficiency with partial pubertal development and detectable FSH levels, they were significantly enriched in reversal compared to the other two groups. So this got us thinking, well, if that's really a target subtype, maybe we should think about trying to identify predictors, because there had been no studies to date that had identified predictors, only case reports. So this was work that was begun several years ago and was an international collaboration, which is really exciting because these groups from the US, Finland, UK, France, Italy, and Brazil all collaborated and shared reversal cases and used a harmonized data set, so a minimal data set that was developed in a European consortium. And we used that to make sure that the individuals were being characterized very carefully. And we collected the largest cohort of reversal cases to date of 87 and identified that there were actually 2 distinct groups of these reversals. So what we did is in this large cohort, we applied latent class mixture modeling, which identified 2 distinct classes with very high classification probabilities and low uncertainty, meaning that they were distinct. And you can see here in this left-hand panel, the non-reversal are shown in red, and the figure shows that there's no overlap between the green and blue. These represent the distinct probabilities as in terms of testicular volume of fitting the reversal class 1 or class 2 using a multinomial regression. So they are distinct classes and indeed separate. Then we combined the 2 classes and as a function of maximal testicular volume, looked at their likelihood of reversal. And you can see that as just like the Pasqualini syndrome were enriched for reversal, as the testicular volume gets larger, those error bars get smaller and there's a greater likelihood of reversal. So what does this mean in terms of what these classes look like? So, well, class 1 was a smaller group. They exhibit a milder GnRH deficit, like the Pasqualini syndrome. They have no cryptorchidism or micropenis. So their mini puberty appears to have been intact. They had a statistically significant and large testicular volume. You can see the confidence interval here, and they had higher serum FSH levels. Class 2 was a larger group, and they represented a more severe GnRH deficiency because while it's lower than an overall population percentage of cryptorchidism and micropenis, some individuals in class 2 did exhibit this. And so we see 15% with mal-descended testes and roughly a quarter with micropenis. They had a significantly smaller testicular volume and significantly lower FSH levels, and those were the differentiators between those 2. So we took these 2 classes and then compared them to a reference cohort of CHH cases who were evaluated after washout but did not reverse. And here we saw, we had 87 reversals, and then we compared them to the non-reversals, these deeply phenotyped non-reversals, and there were 108 of these CHH male cases. Between the groups, there were no treatment differences, so they were similar in terms of percentage who received testosterone replacement therapy or TRT, similar in terms of percentage of those who had received gonadotropin therapy as well as pulsatile GnRH. So they didn't appear to be any different on treatment. However, when we looked at the non-reversals, they were more likely to be anosmic, to have Kalman syndrome compared to the reversals. They were more likely to exhibit cryptorchidism, even though some of the reversal cases exhibited cryptorchidism, the non-reversals were much more likely to have cryptorchidism, and they were much more likely to exhibit a complete absence of spontaneous puberty at baseline, meaning their testicular volume was less than 4 mLs. Again, among the non-reversals in terms of genetics, they were much more likely to have oligogenicity. So again, we're getting some insights into this gene dosing effect. The more aggregated genetic variants we have, pathogenic variants, the less likely that axis is to undergo a recovery. And we also saw a complete night and day difference in terms of ANAS1, which was formerly called CAL1. This is the gene that underlies the X-linked form of Kalman syndrome. So we saw 10 out of 108 harbored an ANAS1 variant in the non-reversals and no cases within the reversals. So these were categorically opposed. And then among the reversals, they were enriched for gonadotropin releasing hormone variants in gonadotropin releasing hormone receptor. And that was significantly different. There was a trend towards approximating significance in some other genes, but did not reach statistical significance. And I'll share a little bit about that on a subsequent slide. So as I said, there were 30 genes have been implicated in cases of reversal. And here we see kind of this pathway of GnRH biology and migration. And some of those genes are involved in GnRH neuron specification and migration. And you can see those genes here. This was among the cohort of 87 reversal cases. There are also defects in genes that affect GnRH neuron activation. So TACR3 was one of those, and this is one that often presents with signs of absent mini-puberty, and this gene encodes for neurokinin 3 receptor in those Candy neuron complex. And of course, the enrichment was really in GnRH action. So these are the individuals with GnRH receptor variants, and that was statistically enriched among the reversal cases. Now, Interestingly, earlier this year, there was some very provocative data that was published by Jacques Young and colleagues, which he showed identified a consanguineous family, 3 cases of CHH, and within this, they all harbored a well-documented, demonstrated pathogenic variants in KIS1. And in fact, 2 of these individuals had well-documented cases of reversal. So this is very provocative and really invites us to challenge our thinking about is KIS1 really essential for GnRH signaling? So again, some very provocative data which may uncover some new biology given the difference in the genetic defects found in cases of reversal. So I'd like to move on to some management considerations. So 6 key concepts for management that I think are real important for take home. So reversal always occurs following a period of normalized serum T levels. So this means they're on treatment for a period of time and they have normal serum T levels. Olfactory phenotype, whether someone's Kalman syndrome or normosmic, does not reliably differentiate reversal from non-reversal. Now, I showed you in data that the non-reversals are more likely to be anosmic, but the olfactory phenotype alone is not a reliable differentiator. Reversal can occur even in cases of severe GnRH deficiency, including those with signs of absent mini-puberty. And a hallmark, this is a really important point, hallmark sign of reversal is testicular growth on testosterone replacement. So normally we would expect to see no change in testicular size. So when we see testicular growth on TRT, that suggests that there's been some activation of the neuroendocrine component, and those gonadotropins are stimulating some testicular development. All treatment washouts should be closely supervised, again, because there can be relapse. And because there is relapse, these individuals warrant close monitoring and some education to help patients be able to understand what are the signs and symptoms that may indicate that they've tipped back into a hypogonadal state. So we'll start first with a targeted management approach. So this is kind of exciting because it's the first approach to a targeted management of CHH. So those thinking about those who are more likely to reverse, these will be milder GnRH deficiency with no micropenis. They will have detectable FSH. So with some spontaneous pubertal development. So about 4 IUs per liter will be the FSH, and the partial spontaneous puberty. Again, that Pasqualini syndrome is around 8 mLs, which is consistent with, compatible with spermatogenesis, and those individuals with GnRH receptor variants. So when we assess reversal, the when and how include that most of these reversals happen in early adulthood. So when we looked at these data, of course, we didn't follow them longitudinally, it's cross-sectional and historical, but most of them reverse early in their 20s. So that's really appears to be a peak area. It's unclear whether that's an period of development with some neuroplasticity, but that is just an observation that we saw. Watch for testicular growth on TRT, normalize those serum T levels for about 6 months or longer, and then have a supervised treatment washout. Repeat the hormonal evaluation, and if the T levels are normal, monitor for relapse and teach individuals about signs and symptoms of hypogonadism. And if there's no reversal or relapse, that merits a prompt return and restarting of treatment, because we want to avoid and mitigate those negative sequelae from people being non-adherent with their treatment. When we think about those less likely to reverse, these are more likely to be more severe GnRH deficiency. Now, some individuals with severe GnRH deficiency can reverse, but this is a general trend. So signs of absent mini-puberty, cryptorchidism, micropenis are also going to be indicators. Absent spontaneous puberty and forms of syndromic CHH, where we overlap with non-reproductive phenotypes. In terms of genotype, anyone with a NOS1 variant, or if somebody doesn't have access to genetic testing, one could take a detailed 3-generation family history and determine an X-linked inheritance, and that could be suggestive of an NOS1 that could help guide clinical reasoning. And anyone with oligogenicity, 2 or more variants, is going to be less likely to reverse. So in these cases, where we want to focus our management efforts are really on adherence to treatment. We want to focus on ascertaining fertility goals, because testosterone will inhibit fertility development that requires gonadotropins or pulsatile GnRH. I always focus on psychosocial well-being and managing those comorbidities in terms of bone and metabolic health. So to finish with some summary points, the reversal phenomenon really challenges the classic dogma that congenital genetic disorders are lifelong. This is a really fascinating event, and the fact that individuals harbor genetic variants suggests that there's some epigenetic effect and mechanism underlying this. It occurs in about 10 to 15% of men and always follows normalized T levels. It's a hallmark sign is testicular growth on testosterone replacement. It can occur with severe GnRH and those harboring pathogenic variants, and it can relapse. So it merits close monitoring, and genetic studies and careful phenotyping can target reversal surveillance, which is really the first tailored management approach for this rare endocrine disorder, which I find is really exciting. I want to acknowledge and thank my amazing collaborators from around the world. I couldn't do this work without their collaboration, and this was a collaboration of a higher order, which I'm really excited about. And I've included my email here if you have questions or concerns that you'd like to contact me with. So thank you so much, and I will stop there.
So thank you very much, Andrew. And Klaus, maybe.
Yeah, yes, has Chana arrived?
Yes, Chana's here.
Okay, so I would very much like to introduce the last speaker, which is Chana Jayasena from the Imperial College London, and he's going to talk about induction of fertility in male patients with congenital hypogonadotropic hypogonadism. So, Chana, over to you.
Thank you, Klaus. Thank you for that very kind introduction and for a fantastic seminar it has been so far. So what I'm going to do is talk about some practical elements about treating men affected by congenital hypogonadotropic hypogonadism. I lead a fertility service focusing on male fertility in London. So before I go on, I just want to, I guess, focus the key elements that are needed for achieving spermatogenesis. So you have this very well characterized approximately 3-month-long process where through mitosis and meiosis, you get the production of elongated spermatozoa. Now, almost all of this is predominantly FSH dependent. So the kisspeptin dynorphin neurokinin B pathway that we've been hearing about regulates these pulses of GnRH, and that leads to pulses of FSH secretion, which activate the Sertoli cells to take you to the spermatid phase. But the final step of sperm maturation requires very high levels of intratesticular testosterone in order to achieve sperm maturation. And that is, by contrast, Leydig cell dependent under LH stimulation. And in CHH, the thing to distill from this image is that you get this inadequate FSH stimulation of the Sertoli cells and LH stimulation to achieve this sperm maturation with high intratesticular testosterone. So in terms of approaches to sperm induction, there has never been any randomized controlled trial. This is a rare disease, and therefore different recipes, I like to call it, or protocols have arisen, but they have commonalities. Most commonly around the world, gonadotropins, which contain LH and FSH activity, are used. GnRH pump therapy is in theory an excellent option and has been used and published very well, but practically has poor availability, so I won't be talking about that. And things such as selective estrogen receptor modulators and anastrozole are unsuitable because you don't have competency of the pituitary or hypothalamus, but so they can be used for other forms of male infertility, but I would stress not in this context. So what protocols for sperm induction should we use? And I'm presenting an unbiased approach, so I'm going to show you 3 nuances of a very similar protocol, which we know that high volume centers around the world use. So protocol 1 is basically you want to achieve an increase in intratesticular testosterone, and the cheapest way to do that is with something called coronate gonadotropin, which is a very potent and long-acting form of LH, which is urine derived. I will typically use about 2,500 units twice weekly. Depending on your formulation, they have different potencies, so you may need to adapt this to the local forms of HCG that you have. And then what you try to do is within 6 months, ideally, is to titrate up that HCG to get your testosterone levels into the mid-range. Now, if by 9 months, let's say they are still azoospermic, then we would add something with FSH activity. We use menotropin a lot, which is urine derived and has a lot of FSH activity. Recombinant forms are also available. And you would increase progressively the FSH dose if they remain azoospermic. And as I will show later on, we would expect a full response under optimum conditions within 2 years. And we tend to advocate serum testosterone measurements regularly, and from 6 months onwards, semen analyses. So that is protocol 1. Protocol 2, which I tend to use more in congenital hypogonadotropic hypogonadism, because they often don't respond to HCG monotherapy, is just to add FSH straight away. So rather than starting with HCG alone, where we're just getting Leydig cell stimulation, we're also adding FSH to, and there is no proof whether this is better, but this is an approach that many centers use, where you simultaneously start both gonadotropins and you simultaneously titrate up the HCG and later increase the FSH, trying to wait for the floodgates to open and for sperm to appear in the ejaculate. And then there's a much talked about study which the previous speaker, Professor Dwyer, led during his time in Lausanne, which was actually advocating for men with very small testes, say below 4 mils, whether 4 to 6 months of FSH pre-treatment in order to stimulate and grow the seminiferous tubular network, the machinery for making sperm, might be better for achieving outcomes in the long term than starting with HCG alone. So we personally, with men with very small testes, will do this and give FSH pre-treatment before we add in the HCG to the FSH, and again titrate up the doses of both. It's, as you've heard already, it's really important to keep an eye and document at baseline, but also during treatment, testicular volume, which is a really good indicator of response to treatment. And so in summary, what protocol should we use? Well, they all have the commonality of giving HCG to induce intratesticular testosterone and FSH to induce spermatogenesis, but we don't know which protocol is best head-to-head, and adapting to local drug availability is certainly advocated. And we're coordinating an international study with lots of collaborating centers to try and see through multivariable regression whether there are any factors which are associated with better outcomes than not. So what factors influence the success of sperm induction? So the state of the art is we know about factors that are associated with sperm, but much less about pregnancy. So with sperm, we have this very nice meta-analysis from Florence, where they showed, we're looking at forest plots, that so anything towards the right is associated with better outcomes, that having hypothalamic related, so congenital hypog has a lower success than pituitary, which you would expect. The pituitary would be obviously having full pubertal maturation of the testes. And as you can see here, adding in FSH is more likely to be associated with success than HCG alone. And interestingly, there's no significant difference between previous testosterone therapy or none. Looking in that in more detail, they did what we called a meta-regression. So each of these circles is a study. The bigger the circle, the bigger the study. And on the x-axis, we're looking at how enriched their cohorts were for previous testosterone use. So towards the right here, we can see studies where everyone had testosterone, and in the left, hardly anyone had testosterone prior to treatment. And because the regression line is not significantly different to the horizontal, then we conclude there's no significant interaction between testosterone treatment and sperm induction success. And so what I previously showed you were factors interacting with the probability of any sperm, if we look at something similar, so sperm concentration, well, we can see that again the adult onset hypog have better sperm outcomes than the congenital, and we can see that adding FSH to HCG is associated with better sperm concentrations than HCG alone. This is a really nice piece of work from Milan, and what they also showed was that in this nice small cohort of men with congenital hypogonadotropic hypogonadism, that actually having cryptorchidism and also a positive genetic background was associated with poorer testicular growth as a good surrogate of successful fertility treatment than those who were negative for these factors. So just to summarize the factors that are influenced, that are known to be associated with success, so normal sexual development, an absence of cryptorchidism, normal puberty, bigger testes, the use of FSH, and an absence of genetic background are all positive factors. But there's no data suggesting that previous testosterone use therapeutically or the type of FSH, whether it's recombinant or urinary, makes any difference. One thing that we don't know, there was some nice data presented by David Handelsman's group at Endo, but it's not published, is that increasing female age so a female factor intuitively is likely to play an important component, which is much more relevant if you have couples who are in their 30s rather than in their 20s. How quickly do patients respond to sperm induction? So this was really nice work done by Peter Liu when he was working with David Handelsman. So what they did was follow up about 70, if I recall correctly, men with hypogonadotropic hypogonadism. This was all comers, so this included acquired as well as congenital. On the x-axis, we're looking at months to an outcome, and on the y-axis, the proportion of men who achieved this. And if you look at the top line, this is the number of men who who saw any sperm. You could see that the last response happens at 24 months, which is the root of how we counsel men. And it's interesting, the light circles show pregnancy outcomes, and it shows that actually achieving about 5 million sperm per mil closely mirrors pregnancy. So this really underlines the fact that you don't need to achieve perfection to actually achieve a response. And very few men, as you can see by the bottom line, achieve a normal sperm count. And particularly in men with CHH, you wouldn't expect that. So the median concentration during pregnancy was 8 million sperm per mil. So just to summarize this, 24 months was the maximum duration for seeing any sperm. But it took 3 years to get final pregnancies, but we don't have current data for CHH. This included all men with hypogonadotropic hypogonadism. What counseling should we give men and couples? Well, I think we should talk very carefully about the timelines, otherwise they will think after 6 months, why haven't they got a baby, or are they pregnant? Some couples do need assisted reproductive technologies, so thinking about older couples and looking at the couples, particularly if the female partner has anovulation or obesity, it's essential to deal with these things earlier. And also thinking about funding, whether they can afford treatment, is there government funding in place? And always asking, so I think it's always a pitfall not to actually bring their partner in at least once so that you can counsel them both, advising on regular intercourse once there are any sperm seen. So the moment there are any sperm in the ejaculate, then by definition they could get pregnant. And there's no need to time intercourse the menstrual cycle. That advice really holds for men with normal sperm counts, but not for men with very little. I find this is actually very useful for endocrinologists. So something that fertility specialists use a lot is something called the total motile sperm count. So the volume times the concentration times the percentage motility tells you how many sperm are moving in the ejaculate. Clearly, if someone is aspermic, they can't conceive. And if they have less than 1 million moving sperm, they could conceive, but it's difficult. And they're the most likely to need referral for assisted reproductive technologies. Most men in the CHH category, we hope will get to the 1 to 20 million, and none of them will get to the reference range. So this gives you an idea about when referral for IVF and ICSI is likely to be needed. So just to summarize, I've taken you through a summary, hopefully unbiased, about different ways that we can stimulate sperm through gonadotropins. There are different protocols, and we need higher quality outcome data to tell us which elements of that are best. But my advice is to adapt to your local availability of drugs. They all work. It takes up to 2 years to see sperm, and there's no evidence that previous testosterone treatment is detrimental. Set realistic expectations to effectively counsel your couple, and don't forget general family planning and liaison with your fertility services. Thank you so much.
Thank you very much, Jana, and thank you to all speakers. And if there are any pertinent questions, we will take them right now in the audience. And I saw one question, and that was to Andrew on reversal. And I think you answered that in your talk, but the question is, has reversal ever been seen with ANOS1 variants? And I think the answer was no, but you may be able to
yeah, maybe you can comment on that, and I don't know if you have any idea why ANOS1 is the only one, or it's so difficult in the case of ANOS1 to have a reversal. So
Yeah, I think we did not see any evidence of reversal with individuals harboring pathogenic ANOS1 variants. Previous work by a number of groups have demonstrated very clearly that that particular gene, pathogenic variants in that particular gene, result in a very severe phenotype. So these are people who have very small testes, they have higher rates of cryptorchidism, and their fertility outcomes are the worst among patients. So those are the people who would benefit. Dr. Jayasena said, I know that sequential treatment of FSH pre-treatment, and I know Tinelli Ravio has demonstrated that using that pre-treatment can work even in individuals with ANOS1 variants. But currently, there's no evidence that we've seen of reversal among those individuals.
do you think that could be dependent on the fact that ANOS1 is so important in the development of the gene compared to the other one? But for example, let's think about FGFR1, which is another very important gene. In that case, we can have a reversal. So do you have any idea about the differences between these two genes?
It's a great question. I would say I can speculate. I think that NOS1 is really important for that GnRH neuron migration. Right? So if the neurons don't get to the hypothalamic region or the arcuate nucleus, there's very little likelihood that there will be a reversal or activation of them. Whereas FGFR1 is kind of has a different spatial temporal expression during development, so it may be important at different phases during embryologic development and during puberty and adult life. So that may account for some of the difference. But again, I'm not saying I have data for that. These are me just kind of speculating about what could be potential explanations.
And there seems to be a follow-up question to the ANOS1 question. Is there a lack of information available on genes other than ANOS1 to give an accurate prediction of outcome for patients?
Yeah, it's a great question. I wish we had a more precision medicine approach. We know that GnRH receptor variants are enriched among. That doesn't mean that everyone harboring a GnRH receptor variant will reverse, but we know that they're among the most likely. TACR3 is another one that was quite prevalent, and that's interesting because many individuals harboring variant in that gene may present with micropenis, which we typically think of as absent mini puberty, and yet individuals with TACR3 can undergo reversal. So I think we're just underpowered to really have a true precision approach beyond the recommendations that I had outlined in the talk.
And maybe also, Klaus, because I think this question was from a patient, and he was commenting that maybe it's not so easy to have a clear answer when we have a genetic result in terms of prediction for the phenotype of the patient. And unfortunately, this is the truth. I mean, as Dr. Cangiano was showing before, the expressivity and the penetrance of the allelic variants are very, very variable. So it's not easy to be sure about the phenotype that will come in the presence of an allelic variance, or either inside of the same family. We know that different person can have a different phenotype. So the only thing that we can do is to register, of course, the genetics, and then to try to follow the patient, especially when we are talking about child of patients that are harboring some variants and that are passing the variant to the child.
Yes, I think.
Okay. I think time is up now, so so the hour that we had is over. So I think we can conclude and say that much is yet to be learned about Hypoc, and thank you to all speakers, and thank you for this very important important contributions that you gave here. Thanks to all.
Thank you.
Yeah.
Thank you.
Bye bye.
Thanks to all. Bye bye.
Thanks so much. Nice seeing you guys. Take care.
Sorry
all.
for the short timing that doesn't allow you to make some question more. Anyway, I think it may be possible.
Appreciate the including us. Anyway, take care.
Thanks for the invite. Be well.